understand completely your frustrations.
It happens almost every single time we try to do something. So this is unusual.
Okay, everyone, we might start. I'm sorry it's late. We've had technical issues with the webinar program, which we're going to be changing by the next meeting, I think, Arjun. Welcome everyone to the first Journal Club of this year, and we will be recording this and putting up onto the website. So we're recording now, Marion. And it is really a great pleasure to welcome my old friend Marion back. We go back to a very long way as registrars at St Vincent's Hospital, and she's had an absolutely stellar career over in the US and has taken a keen interest in antimicrobial stewardship in Australia and really promotes our work very heavily over in the US at the highest levels of the CDC with all her contacts. And she was very keen to come across and talk to us about what's happening in the US at the moment. She's obviously based down in Tennessee, but has a really key role in all the key bodies, including SHE. So welcome. I think your activities will speak for themselves, Marion.
Thank you so much. It's a real privilege to talk to all of you, and I had mentioned previously to Kaz, I actually regularly dial into the NCAS Journal Club from Tennessee with some of my colleagues. So it's a privilege speaking with you. So first of all, antimicrobial stewardship is a team sport. This is a photo of some key team members at the Tennessee Department of Health. And we would not be able to do our work without significant funding from the Centers for Disease Control and Prevention. I'm the only one that is funded by the State Health Department. Everybody else from my team is funded through the Centers for Disease Control and Prevention. And CDC also provides significant technical support. And some of the slides which I'm presenting have been provided by Laurie Hicks, from the Office of Antimicrobial Stewardship at CDC, and Arjun Srinivasan as well. So there has been a massive national momentum on antimicrobial resistance in the United States, starting from the CDC Antimicrobial Resistance Threat Report. Then the CDC developed a Detect and Protect initiative in 2014. There was a national strategy on combating antibiotic-resistant bacteria. I had the privilege of being a member of a 15 group of people as part of a working group for the President's Council of Advisors on Science and Technology, the PCAST report, which went to President Obama. There was an executive order that the President went and signed, which included antimicrobial stewardship. The CDC developed the Antimicrobial Resistance Surveillance Initiative. There was a national action plan. There was a White House forum on antimicrobial stewardship, which I was privileged to attend as well. And then there's the Presidential Advisory Council on combating antimicrobial resistant bacteria. So CARB here is combating antimicrobial resistant bacteria. So it's a good CARB. Okay, so this is what really kicked things off was this antibiotic resistance threat report in 2013, which divided up the most urgent threats in the United States. And it really led to the formation of this working group for the President's Council of Advisors on Science and Technology. And we published this report in September of 2014. This is President Obama's executive order to combat antibiotic-resistant bacteria. It was to strengthen national surveillance efforts for resistant bacteria, a focus on preventing and responding to infections and outbreaks of antibiotic-resistant organisms. And then a significant focus was on antimicrobial stewardship and looking at reviewing existing regulations for hospitals and other inpatient healthcare facilities. And those regulations were proposed, they were supported by the Infectious Diseases Society of America, they were supported by the Society for Healthcare Epidemiology of America, a lot of support, but then they got stuck in the regulations. And when the new administration came in, they have not actually been promulgated or finalized. There were similar regulations which were proposed for the long-term care facility sector, which were focusing on infection control and antimicrobial stewardship, and those did get passed. Those were implemented before the change of administration, and they have completely changed the landscape of antimicrobial stewardship in nursing homes, as well as infection control in nursing homes. There is a significant initiative for Department of Defense and Veterans Affairs hospitals on antimicrobial stewardship, and there was a strong push to monitor improvements in antimicrobial usage through the National Healthcare Safety Network, or NHSN, which is a national surveillance system where we capture information on healthcare-associated infections. The facilities can go and see their data. They can benchmark. We at the State Health Department have access to that information. We use it for public reporting. It is also reported to the Centers for Medicare and Medicaid Services, where it is also published there, and it is used for payment purposes as well. So the National Healthcare Safety Network is a massive infrastructure which helps support infection control as well as antimicrobial stewardship in healthcare settings. So CDC had initially the strategic framework, then they had the National Action Plan for combating antibiotic-resistant bacteria, or CARB. There was this White House Forum on antibiotic stewardship, and I had the opportunity to attend that, and in my hand I had the therapeutic guidelines. And I mentioned those therapeutic guidelines, how it was so nice to have everything in one place, that the different societies all decided on this is what the recommendations are. And Tom Frieden, who was the director of CDC at that time, really took that to heart. That was his major take-home message from that Antimicrobial Stewardship Forum. And that led to him asking the Healthcare Infection Control Practices Advisory Committee, or HICPAC, and I serve as a liaison to HICPAC, to develop a guidance document for professional societies when they develop guidelines, therapeutic guidelines, so that at least in the future going forward, professional societies will develop treatment guidelines taking antimicrobial stewardship principles into account. And that's sort of like one step forward to trying to get to something such as the therapeutic guidelines, because that we can't get to straight away, but at least trying to incorporate antimicrobial stewardship principles. So this is a guidance for guideline development, and they recommend that explicit recommendations for antibiotic stewardship relevant to infections should be addressed in these guidelines. And so these include principles of diagnostic testing as well as treatment. They should present the advantages and disadvantages of diagnostic tests and antibiotic treatment choices with respect to efficacy and adverse consequences, and recommendation for patient education regarding diagnostic testing, antibiotic therapy, and duration of therapy when feasible or appropriate. And then these are some examples of the principles of testing in terms of making sure that they should be used wisely, talking about the role of rapid diagnostic tests and biomarkers, how bacterial cultures should be handled. So making sure that we're looking at all the different aspects inside with regards to the principles of testing, avoiding diagnostic testing without an appropriate clinical indication. That's something which is really important. For example, the taking of urine cultures. When people don't actually have a urinary tract infection, people then treat asymptomatic bacteriuria as a major driver. and then talking about the principles of treatment, really the really basic stuff, including making sure that we've got source removal and all of those kind of things. So these were finalized and then published in September of last year. So I encourage you to have a look at that. And if you see that there are any gaps in there, things which are not included, I would really welcome you to tell us so that we can update this, because this is supposed to be a living document. So if you see any gaps, please do let us know if we have not addressed those. So I had mentioned the rules and regulations. These were published in the Federal Register, and these were the ones from the Centers for Medicare and Medicaid Services, which pays for the vast majority of care in the nursing homes and long-term care facilities. And these have had a very significant impact on pushing nursing homes to implement antimicrobial stewardship. So October of last year was this date that they needed to start implementing antimicrobial stewardship programs. And it had been quite a challenge trying to get our nursing homes to participate in antimicrobial stewardship activities. They have had so many other competing priorities, and now they're coming to us willing to absorb any education which we can provide and any additional support. So it has been an absolute game changer for us at the State Health Department in terms of getting their engagement. And I had mentioned that the rules and regulations for hospitals with regards to antimicrobial stewardship sort of are in the regulation purgatory hell right now. And so Joint Commission, which is an accrediting organization, has actually taken up part of that role. So they're not rules and regulations, but because most facilities in the United States are accredited, and the vast majority by Joint Commission, them adopting these has had a very significant impact, and they started implementing that effective January of 2017. And they really used CDC's core elements of antimicrobial stewardship as their guide. So there's sort of there's harmonization between what CDC is recommending that hospitals do, as well as the Joint Commission for accreditation, which is always helpful. We always like to see harmonization and not have things out of sync, because that can be very confusing for facilities. So I had mentioned the CDC core elements of hospital stewardship. There are 7 of these. They include leadership, accountability, drug expertise, action, which has many, many, many subcomponents, tracking, reporting, and education. So this is what the latest map looks like. There is a patient safety atlas published by CDC. So this is all available online, and it includes antimicrobial resistance data. It includes antimicrobial stewardship data. And you can then drill down and you can export these as CSV files or as pictures. And probably the thing that I think is most striking is the tremendous geographic variation across the United States. So in the United States, in calendar year 2016, 64% of all acute care hospitals met all 7 core elements. And we in Tennessee, we had 67% of our hospitals, which we feel really proud of, because we started off 10 percentage points below the national average in 2014. So we have moved forward, but we have a long, long ways to go in Tennessee. So this is national data, the number of facilities reporting to the NHSN annual hospital survey. I had mentioned the National Healthcare Safety Network. It measures antimicrobial usage, but on an annual basis, there is a general survey that captures information on infection control infrastructure. And added to that, in 2015, using the data for 2014, people had to report as to what their antimicrobial stewardship programs looked like with regards to those 7 core components. And there were about 15 questions which mapped to those 7 core elements. And you can see that in 2014, 40.9% of facilities met all 7 core elements. In 2015, we went to 48.1%. 2016 to 64.1%. And we also had an increase in the total number of facilities reporting. Particularly, there's been an influx of critical access hospitals, which are small rural hospitals which have had much greater challenges in adopting antimicrobial stewardship policies. Not surprising, it's probably a trend worldwide. So here you can see for 2016, dividing it up by the type of healthcare facility, what proportion met all 7 core elements. So the rural critical access hospitals were at 43%, which is where people were nationally about 2 years earlier. Surgical hospitals at 58.1%, general acute care hospitals at 69.5%, and children's hospitals actually did the best overall at nearly 74%. You can see that there's a significant step up as the larger the facility is, the better they were in being able to implement that antimicrobial stewardship program. So if you were less than 50 beds, it was 46%. And most of those were actually critical access hospitals, so they correlate fairly closely to that. 69% in those which are between 50 and 200 beds, and 81% for greater than 200. And not surprisingly, major teaching hospitals did better than the non-major teaching hospitals. Then if you want to go and see what the uptake has been between 2014 and that should be 2016, you can see the uptake among general acute care hospitals. Critical access hospitals started off really low, only at 20%, and they're now up to 43%. And children's hospitals really jumped up between 2015 and 2016. So I had mentioned in 2014 in Tennessee, we were only 29% of our hospitals had met all 7 core elements of antimicrobial stewardship, versus nationally we were at 39%. So we had a lot of work to go and do. And what we actually looked at is we looked at what proportion of, was there geographic variation in Tennessee? And so there was massive variation nationally among the different states, but even within our state, we had this enormous geographic variation. And so Tennessee is a really long, thin state between Memphis in the west and the northeast. That distance is equivalent to the distance from the northeast of Tennessee to the Canadian border. Okay, so we are a very long, thin state. And up in the northeast area of Tennessee, which has been our hotbed for carbapenem-resistant Enterobacteriaceae, only 10% of the hospitals there, and there's about 8 hospitals there, actually met those 7 core elements. But they were right next door to the Knoxville surrounding hospitals, where 45% met those core elements. And so it's fascinating to see just this enormous geographic variability, but it also allowed us to do the appropriate targeting. So I think one of the things that our program is really good at is data for action and understanding where we need to target our interventions, because while we are a health department that is well-resourced, we don't have the resources to help everybody. So we need to really go in where we can have the biggest impact. So we looked at the data in 2014, and in Tennessee, only 23% of facilities had salaried support for antibiotic stewardship activities. And when you looked at documentation of indication for antibiotics in the medical record, and you can't really look at the appropriateness if you don't have documentation of indication, only 20% had a policy requiring that. And of those, only about half even looked at adherence to that policy. So we thought, hang on, this is something which was really important to go and focus on with regards to antimicrobial stewardship. And then we looked also at treatment review or timeout, how many had a policy to review antibiotics after the appropriateness of antibiotics at or after 48 hours from initial orders. And here we arranged between 10% and 33% of our hospitals had that. So we thought that these were areas which we would really want to go and focus on to work on. So in Tennessee, we have about 112 hospitals. Most of those are private hospitals. We have very few public hospitals. And there is a state organization called the Tennessee Hospital Association, for which the vast majority of our hospitals are members, not exclusively, but the vast majority. And they speak really to executive leadership. They have the ear of the CEOs, okay? So we have worked very closely with the Hospital Association for many years, since 2001, predominantly on infection control related issues. And we had the opportunity also of working with the Hospital Association. They had a quality group, which included chief medical officers. And so we had the opportunity of presenting the data from Tennessee to this quality board, who said, Marion, tell us what to do. Write recommendations, draft those recommendations, and we will review them, and we will try to get senior leadership approval of this. And so in October of 2015, the hospital board adopted these 5 recommendations. So that hospital demonstration of commitment to antibiotic stewardship by a written statement of support and consideration of dedicated pharmacy clinician and IT staff time for antibiotic stewardship activities. It wasn't as strong as I wanted it, but I needed to have them sign off on it because this was going to go to all the CEOs of all of the hospitals. That all hospitals commit to reporting to the National Healthcare Safety Network antimicrobial use and resistance modules within specified timeframes. We left that a little vague because we didn't know when those rules and regulations were going to state that they were going to be implemented. But we have been very actively encouraging people to participate. And that all hospitals commit to a policy requiring documentation of indication for antibiotic therapy, because we saw that there was a major gap in that. That all hospitals commit to implementing a policy requiring an antibiotic review at 48 to 72 hours. And this was going to be particularly important because at about the same time, we've had a major sepsis initiative. And unless you have that close collaboration, you're going to have a lot of people on empiric broad spectrum antibiotics where there's not going to be an antibiotic review at 48 to 72 hours. And so we didn't want that to counteract our efforts in antimicrobial stewardship as well. And when we're asking facilities to participate in an antibiotic stewardship collaborative statewide to encourage best practice and lessons learned sharing and the development of appropriate educational programming. So we think that that sign-off from the hospital board was actually absolutely key in getting hospital engagement, getting hospital leadership to provide the resources and to move us forward. So when we now look at the proportion of acute care hospitals in Tennessee achieving all 7 core elements, Northeast Tennessee, which had 10% in 2014, we were at 70% in 2016. And that was the area which we really, really targeted. So they actually are now the 3rd highest of all the 8 particular regions in Tennessee. So when we now compare the seven core elements, in red is Tennessee we are a red state. We have a Republican legislature and a Republican governor. And compared in the blue here is the United States. And you can see we actually are outperforming most of the rest of the United States, except for in the reporting area. But I believe in 2017, we will be beating the rest of the United States because of some particular incentives that we have worked on with regards to our hospitals to report to the NHSN antimicrobial use module. So we appear to be outpacing the rest of the country on that. So one of the other tools which we use, and this may be of interest to you, is the National Quality Forum put together a playbook on strategies for each of these CDC core elements. So they have these 7 core elements. And, I said to them, well, it's nice that you've got these, but what do you actually do to get this done? And, and it's not a one size fits all. Different facilities have different needs and opportunities. And so this playbook actually goes through some very basic, some more intermediate, some more advanced steps. And it goes through the different barriers and how to overcome those barriers. And Arjun Srinivasan was heavily involved in the development of this, as well as Ed Septimus from Hospital Corporation of America. And this is a really, really helpful practical guidance book. And so we have very much promoted adoption of this playbook. So how accurate are the assessment of those core elements? They are reported in the National Healthcare Safety Network annual survey. It's infection preventionists that complete that information. We ask them to work very closely with their antimicrobial stewardship team and their pharmacists, but we really don't know how well they do that. So we were interested to understand how accurately does the reporting actually reflect what is happening. So we have on our team now, we have 2 pharmacists who we have recruited. One has had over 12 years of antimicrobial stewardship experience. And we now have contacts with all the pharmacists in all of the hospitals, the ones which are responsible for antimicrobial stewardship. And we sent them a survey with 77 fields which were assessing the NQF playbook interventions, because we didn't want them to just answer, we are doing it. We wanted to understand exactly what they are doing, and then using that information to help understand, did they meet a core element? And we asked them what are they currently doing, what are they working on implementing within the next 6 months and within the next 12 months, so that we would understand where there are gaps or opportunities. So we mapped these core elements. We wanted to understand these specific interventions and to develop, and then this is a work which is in progress, and I would love it if any of you can contribute to this, is we're trying to develop a stewardship risk score with comparison of MDR, multi-drug resistant organism rates from NHSN data such as MRSA and CDI. So we can talk about that in greater detail later on. So this is just a screenshot of part of the survey tool. So in terms of like, does your facility have a policy for prior approval for specific antibiotics? Yes, or to be implemented in the next 6 months, to be implemented in the next 7 to 12 months or later. And we'd be happy to share the tool if anybody's interested. That's in red cap. So we had pretty decent response rate. We had 93 of 110 acute care hospitals responding, so an 85% response rate. Many of them we had to phone call on the phone to cajole them to complete the survey. There were actually 651 potential opportunities for matching across, and we actually only had 55 or 8% discordant results. And 46 or 84%, the survey which we did showed that they achieved a core element, but the NHSN survey didn't. But there was actually a time interval, which was different because they completed the survey for calendar year 2016, and we administered the survey in July of 2017, which probably accounted for some part of that. But it was actually fairly reassuring to us that the vast majority were not over-reporting what core elements they had actually implemented or what activities. So that was very helpful. And you can see the concordance for the core elements on the side. I just chose just a few data points here from that survey. In terms of percent of facilities reporting leadership support, we had 92% having a written statement of support. They had policies and procedures for stewardship programs. It was really nice to see that we now had 45% having funding for IT support, because that was virtually non-existent previously. Salary support, not where we wanted at yet. We're at about 23%. We're now at 42, 43, not where we want to be yet. FTEs dedicated to stewardship programs, and then just a very few, I think it's an individual or 2 or 3 facilities that have incentives for units to improve antimicrobial usage. And then this is a proportion of facilities reporting specific interventions. Everybody had at least one antibiotic guideline, a significant proportion restricted antibiotics. Many had automatic IV to PO conversion, audit and feedback, so but about just under 70%. Antibiotic timeouts, which were a real problem beforehand. We've made significant progress, still not where we want to be, but we are making progress in there. Indication documentation, again, not where we want to be. We still need to work really heavily on that and the use of rapid diagnostics. Tennessee is one of 10 states which are part of the Emerging Infections Program, which means we are fortunate to receive additional funds from CDC to do research. Our other funds are very much more programmatic versus this is much more detailed research. This was a paper which was published in JAMA looking at the prevalence of antimicrobial use in acute care hospitals. This is in 2011. The overall prevalence was just about 50%, but among those 10 EIP states, Tennessee had by far the highest. We had 56.3% on antibiotics. The lowest state had 43.9%. And so this is a common theme. In Tennessee, we use a lot of drugs, whether that is antibiotics, whether that is opioids, whether it's antipsychotics. We are, a pill popping state. We really need to address all of those issues. I think there's a lot of cultural issues involved here. But the antimicrobial usage in prevalence in different hospital locations was quite different. ICUs, medical surgical, med-surg, and heme-onc wards had the highest usage, but overall it was nearly 50%. This is in 2011, and we have just repeated that survey in 2015, and we're currently analyzing those data, but these are the 2011 data. But I thought it would probably similar to here. The most common indications, the top two indications were lower respiratory tract infection and urinary tract infection. So it's fairly similar, but the next few slides will shock you. So of the most common antibiotics, when we're looking at community onset infection, vancomycin was the most common, followed by ceftriaxone, levofloxacin, piperacillin, tazobactam, and azithromycin. These are for community onset infections. Very different to what you see here in Australia. And then when you're looking at healthcare facility onset, again, vancomycin, most common, followed by piperacillin, tazobactam, followed by levofloxacin, ceftriaxone, and metronidazole. So very different distribution using much more broad spectrum antibiotics than I used here. When we look at your data from NAPS, it's very different distribution. So nationally, MRSA rates are coming down. In Tennessee, we have a real problem still with MRSA. Our standardized infection ratio, which is the number of observed divided by the number of predicted infections in Tennessee, is at 1.34. We are one of the 5 highest incidence states. In terms of looking at general communicable diseases, reportable chlamydia is number 1, gonorrhea is number 2, invasive MRSA is number 3. So it is a real problem. And so we have just completed, together with some CDC colleagues and some colleagues in Kentucky, which is just north of us, who are also one of the high incidence states, a really in-depth review of 100 cases in Tennessee and about 100 cases in Kentucky of MRSA bloodstream infections from our top 3 or 4 incident hospitals, and done a really big deep dive to try and understand what is driving this and where there are significant additional opportunities for improvement. And that's, the data have been cleaned and we started some preliminary analysis on that. But it's definitely a problem child in Tennessee, so much so that the Commissioner for Health for us, he wants a report card every month on how we're doing. So my performance is being judged on how the state is doing with regards to MRSA. But nationally, this should not be the driver for vancomycin. CDC worked with a few charitable trusts and stewardship efforts to identify key targets to support the goal of reducing inappropriate hospital antibiotic use by 20% by 2020. And their 2 agents were vancomycin and quinolones, not surprisingly when you see what the most common antibiotics were. And as, again, from a JAMA paper, community-acquired pneumonia and urinary tract infections were the most common indications. And so these are the targets. And when we did the repeat point prevalence survey in 2015 for healthcare-associated infections, we also looked for antimicrobial usage, and we looked at the appropriateness of antimicrobial usage, and we looked at that for vancomycin, the quinolones, as well as for community-acquired pneumonia and urinary tract infection. That analysis is currently underway. We had 24 hospitals participate in that. So I previously mentioned the NHSN, the National Healthcare Safety Network. They are measuring antimicrobial usage. This is not appropriateness, it's measuring antimicrobial usage. It is all done electronically using clinical document architecture, and it is using days of therapy divided by days present in a location. It requires some significant IT support to be able to extract the data from existing CPOE or electronic medication administration record systems, as well as the hospital registry or ADT data, admission, discharge, transfer data, to be able to collect these data, bundle it up, and send it to the National Healthcare Safety Network. So there is absolutely no manual intervention at all. There's no manual keying in. That was done deliberately because the volume was going to be so big. So that's great, except hospitals have not been reporting to it, partly because they have not necessarily had the necessary infrastructure or dedicated the IT resource. So we've had a lag in people reporting to it, which is why we were hoping that the CMS regulations would be pushing for it, making that a requirement. We've had a significant uptake now, and so one of the things we have done in Tennessee is we have tried to incentivize our facilities to report. And if we gave our facilities money, it would just go into the big coffers, and the people who need to drive it would never see a cent of it. So what we decided to do is we were going to incentivize the pharmacists to be the champions to push for this. And what we have decided to do is that we would go and reimburse 2 people at each facility, NHSN facility, upon them submitting the data to the NHSN antimicrobial use module for attending and completing a course in antimicrobial stewardship, either through SIDP, the Society for Infectious Disease Pharmacists, or for MADID, or through SHAE. And normally, pharmacists in the United States do not get professional development assistance, or that would be coming out of their own pocket. So this way we were able to advertise these antimicrobial stewardship certificate courses. We were able to reimburse them, and we have really had a significant uptake now in our hospitals participating in reporting to the NHSN antimicrobial use module. So we're really excited about that. So in the interim, I can't live without data. It's sort of, we work on implementing these core elements, but are we actually making a difference? People can tell me they're making a difference, but show me the money. I want to see the data. So we developed as an interim measure until people could report to the NHSN antimicrobial use module, a fairly simple survey which they filled in online. We only had a requirement for them to send it to us on a quarterly basis. We have some facilities actually reporting to it on a daily basis, but once a quarter is when they are required to go and do it, and we adapted the point prevalence survey. So the way that they do it is, this is not appropriateness, this is pure usage, is the proportion of the census, either facility-wide or by location, and then the number of people who are on any antibiotic, and then we have different classes. So when we piloted it, the pharmacists, it took them about 30 minutes to set up a query inside their software. We were looking at orders, not administration. If we did administration, that would have been a lot more complex. But looking at orders, which are fairly well correlated, not identical, but we wanted to make something that was doable. They're looking at the orders divided by the census, either hospital-wide or by location. So we were curious to know how well does that correlate with the NHSN antimicrobial use module. And we had 4 facilities that participated in both. So they had reported to the NHSN antimicrobial use module from October of 2015 through December of 2016. And we pulled these data and then we matched these data, and we wanted to see how well it correlated. So we had 9 different antibiotics or groups of antibiotics. We had 117 matched data points. And we were really shocked that it actually correlated pretty well, considering that we were doing a sampling of only a minimum of once per quarter compared to daily. And so this is looking at all antimicrobial usage. When we're looking at anti-pseudomonal carbapenem usage, it actually correlates fairly well. And it correlates well for every other group of antibiotics, but the one place it does not correlate at all is respiratory fluoroquinolones. And our hypothesis is it's maybe driven by a sampling error, because we only ask them to report it once per quarter. And when we're talking about, especially in the respiratory season, we may catch it earlier or later versus NHSN captures the data on a daily basis. And so we think that that may be a driver. So we're investigating that a little bit more closely. But we were pleasantly surprised that as an interim measure, this was something that was going to be helpful. And when we actually looked at individual institutions who we knew had a very fledgling antimicrobial stewardship program earlier, and then had developed a more robust antimicrobial stewardship program, at least on paper, we could actually see an impact in terms of actually seeing a decrease in antimicrobial usage. The other thing which we identified is that there's quite significant seasonal variation. So we had to go from we correlate quarter from the previous year to the quarter now, because there was very significant seasonal variation. So you couldn't just compare to your previous quarter. So now I've been focusing previously on hospitals. I'm going to talk a little bit on antimicrobial usage in the community. Again, this a patient safety atlas from CDC, which looked at the core elements of antimicrobial stewardship in hospitals. It also has maps of the usage, the community antibiotic prescribing rates per 1,000 persons. And the data source here is the IMS Health data source. And they've just changed names 3 times in the last few months. So I apologize, I may have misquoted what they're called now, but that is the underlying data source. And in the United States, overall, it's 877 prescriptions per 1,000 patients in calendar year 2011. Massive geographic variation again. So when we're looking at our lowest state, it's Alaska at 588 prescriptions per 1,000, compared to West Virginia, which is here, which is 1,355. California at 622. Kentucky, which is here, 1,000 is this, but the lowest versus the highest ranks down there. And Tennessee in 2011 had the third highest usage. As I mentioned, we really use antibiotics a lot in the inpatient setting, in the outpatient setting. We use a lot of antipsychotics in our nursing homes. There's a major initiative underway, and we are part of that belt that in Appalachia that has a real problem with opioid prescriptions, opioid epidemic. So this is for 2011. So in the United States, 877. In 2015, it's gone down to 838, a little bit of progress. I'm happy to say Tennessee went down. We're now number 5. We're making progress. We are still not where we need to be. We have a lot of work to go and do. So West Virginia, Kentucky, Mississippi are the 3 highest states. Again, this massive geographic variation. So when we are looking as to, on a national basis, what progress have we made, the predominant progress has really been in the pediatric population. That it has been a focus from the Centers for Disease Control and Prevention in their outreach. They have really worked very hard for looking at the pediatric population. That has been a target, and we're seeing progress. Not as much as we would like, but we have seen some progress there. But among the adults, there has been very little progress. So that's something which we will need to go and focus on. So all ages decreased 5%, pediatric decreased 14%, adults no change. So how much antibiotic use is unnecessary in outpatient settings? At least 30% are unnecessary prescriptions, and this is probably an underestimate. They were being very conservative about this, and that really represents a lot of patients who undergo unnecessary risk for developing Clostridium difficile or antibiotic resistance. If you haven't read this paper from Catherine Fleming-Dutra, I recommend that. That's an interesting paper to go and look at. When we're looking at improving outpatient antibiotic selection, we're looking here we're looking at pediatric middle and ear infections, pediatric sinus infections, adult sinus infections, pediatric pharyngitis, and adult pharyngitis. And the dark blue represents first-line antibiotics. The red looks at non-first-line antibiotics, and the grayish looks at first-line alternative antibiotics. And among the 3 most common diagnoses leading to antibiotics, 52% received first-line therapies. So not only do we have a problem, okay. I'll finish. Yeah. So not only do we have people prescribing antibiotics unnecessarily, but when they prescribe them, they don't prescribe first-line antibiotics a lot of the time. So we have some significant additional things. And so I may stop now.
Sorry.
That's okay, not a problem. We've got a whole lot of people there, so thank you very much.
We can't continue now, but Marion's speaking at 12:30. Where is the meeting? Up in the upstairs on the 5th floor. So I've got quite a few questions for you, but I'll hold it off until lunchtime. Thank you very much, Marion.
Thank you.
Sorry for the late start.
Happens. That's okay.
Are these all yours?
Yes, these are mine. Thank you.
How many more slides did you have?